Have my seat if you'd like and come and do this bit. Very happy.
Great, okay, in which case we will get started. So, good afternoon and welcome to this afternoon's event, Ending the Postcode Lottery, How Policymakers Can Address Health Inequalities Across the Country. We are the Social Market Foundation. We're a cross-party think tank founded in 1989, and we give policy advice to government and politicians right across the political spectrum. Thank you so much for coming to this really important discussion on health inequalities. This is a widespread issue right across the UK, where in the most deprived areas, life expectancy is actually 18 years lower than in the least deprived, so a really serious issue that we're talking about this afternoon. And at this event, we'll explore the persistent health inequalities and what's impacting them, so issues like what someone's gender is, their ethnicity, where they live, housing, income, all of those issues feeding into this. My name is Dr. Rebecca Montacute. I am the Research Director here at the Social Market Foundation, and I'll just do a few quick bits of housekeeping before I introduce our panel, who are exactly perfectly on time for that. So please do not post about, please do post about this event on social media. That is a good thing to do. We are at SMF Think Tank on socials, and I also want to use this as an opportunity to say a huge thank you to Policy at Manchester, the University of Manchester's Policy Engagement Unit, for their support at this event. You can find them on @UOM Policy, and that's also just up on the banner there. So we are recording this event, so it will both be live streamed, which is just going on at the back, and we'll also be clipping bits of this for social media. If you've got any questions about that, please do speak to a member of our team. Please also take note of the emergency exits. There isn't a fire alarm planned, so if that happens, then it is indeed real. So I'm going to introduce our panel, and thank you so much to all of you for joining us today. So we have Professor Arpana Verma. She is the Clinical Professor of Public Health and Epidemiology at the University of Manchester. We're also joined by Tom Almond, Health Analytics Lead at the British Heart Foundation, and Dr. Luke Evans MP, who is the Shadow Minister for Health and Social Care. So without any further ado, Arpana, if you could tell us about the insights from your own research and the issues you've seen around health inequalities.
Thank you so much, and it's a great honour to talk to you today about something that's very close to my heart. So I've been researching inequalities for about 20 years now, and one of our first projects really focused in on how do we actually measure these inequalities and how do we then compare between countries. And one of the key things that we found right at the beginning was that if we look at things at country level, we mask a lot of the things that we're observing in our neighbourhoods, and especially with our most vulnerable populations. So over the course of 20 years, we've seen a range of different actors involved with why these inequalities exist, and from all of the protected characteristics, thinking about how we look at the wider and the social, and now we're thinking about the commercial and informational determinants of health, and how these are all interacting to actually, from when I first started, we're seeing a widening of that gap emerging. And one of the key things about not leaving any of our vulnerable communities behind is working out how best to do it. And one of the key roles for all of my research is to say that we don't know, either as researchers and as many of the policymakers. We need to be listening to our communities, and what they often say to us is that we're talking to people but nobody is listening to us. And we often have these cycles for both research and policy that are quite short, certainly if we're looking across the life course. So how do we think about the whole system's way of identifying these intractable problems that are occurring. And from our research, as well as global research, we know that vulnerable communities are living during their working age with not just one, but multiple morbidities. So multiple different diseases that can be affecting their ability to do work, to play, and to have a full life. And this isn't the same in our affluent communities. And those disparities that we're seeing in both health outcomes and the way that we're looking at the different parts of what makes the healthy choice the easy choice is to start with our communities. And one size isn't going to fit all. And that's one of the other key messages that our communities have been saying. We often describe these communities as hard to reach or underserved. And one of the key things that our experts through experience have said is that we're not hard to reach, it's just we're easy to ignore. And so through our research, and we've got multiple different projects that are currently underway, we've been looking at that whole systems approach. And one of the current ones here in Manchester is the Health Determinants Research Collaboration funded by the National Institute of Health Research. And with Policy at Manchester, we're working with our communities, with the council, to try to bring about that whole systems change for the most vulnerable. We also have a hypothesis that we need to be doing good science. We know that the people who recruit into our different trials are often the same types of people, not necessarily reflective of the communities that we serve. So another big chunk of my research is on how do we make research more inclusive. And what our hypothesis is that if we're doing the right research, i.e. good science, we need to have our most vulnerable included, and our aim is that we can tackle inequalities by doing good science and making sure that the right people are included in all of the interventions that we're doing, and being able to think about then, when we do have research that shows us different opportunities for making a difference, are they actually representative of the populations that we're trying to serve? So thank you very much. Thanks, Vicky.
Thank you so much for that really helpful introduction to the issues that we're talking about this afternoon. Tom, can you tell us a bit about how these issues are impacting the nation's cardiovascular health?
Yeah, sure thing. Thank you very much for having me today, and excuse my timekeeping. I actually do look after all things numbers at BHF, but that does also apparently mean watching the clock a bit more closely. Cardiovascular disease is one of the most popular diseases in the United Kingdom. Over 7.6 million of us living in the UK today are living with a cardiovascular condition. They cause 1 in 4 deaths in the country every year. That's also amongst under 75s. Around 49,000 people under the age of 75 die from a cardiovascular condition like a heart attack or a stroke every year in the United Kingdom. They're also really expensive. The NHS spends about £12 billion a year treating cardiovascular disease. And when you factor in the wider costs of poor cardiovascular health, like disability, informal care, the actual costs of cardiovascular disease to the United Kingdom each year are estimated to be more along the lines of £29 billion. So a lot of people live with a cardiovascular condition. They're really impactful on people's day-to-day living, and they're very expensive. They're also a disease that has inequalities at its very core. Right the way from your risk of getting a cardiovascular condition in the first place, all the way to your chance of dying at a prematurely young age from something like a heart attack or stroke. And we see that all the way from the beginning when we look at cardiovascular risk factors. So, for instance, the prevalence of obesity is 15 percentage points higher in the most deprived parts of England than it is in the least deprived. The prevalence of smoking tobacco, it's 4 times as common in the poorest parts of Scotland than it is in the least deprived parts of Scotland. And when we look across almost every major cardiovascular risk factor, hypertension, diabetes, we see that they are more common in the poorest parts of the United Kingdom. And that translates to more people in more deprived areas living with poor cardiovascular health. In fact, about 50% more people, when you account for differences between local authorities in age, are living with a cardiovascular condition in the nation's most deprived parts. And unsurprisingly, and this will be a slightly depressing intro, apologies, that translates to poorer cardiovascular outcomes in the nation's poorer areas. The rate of dying under the age of 75 from a cardiovascular condition is about twice as high in the poorest parts of the UK than it is in the least. And in England, cardiovascular disease is the single largest disease contributing to the gap in life expectancy between the poorest and least poor parts of the country. And because deprivation isn't spread equally across the country, that also leads to some really stark differences in geographic cardiovascular health. So if we go, for instance, hour 15 minutes up in the car down towards Blackpool, which is the local authority with the nation's worst cardiovascular health, the rate of people dying under the age of 75 from something like a heart attack or a stroke is actually 3 times higher than if we looked at a local authority like Hart in Hampshire. Then it translates to regions as well. So we're in Greater Manchester, we're in the northwest. Your chance, if you're an under 75 in the room, of dying before the age of 75 from a cardiovascular condition is 50% higher than someone living in the southeast. It's really quite shocking. But hopefully, depressing part of the talk over, and I have just focused there on inequalities relating to deprivation and geography, but I'm very happy to take questions on kind of sex and gender and ethnicity as well, because they're all associated with cardiovascular disease. You cannot take the wider determinants of health away from this disease area. What can policymakers do? Well, I mentioned earlier that up to 80% of the burden of CVD is attributable to what we'd call modifiable risk factors. So things that we either as a society, as government or clinicians can change that might reduce somebody's effect. So things like managing hypertension, having a healthy diet, not smoking. Well, the diet is a huge part of this, and one of the things that we've seen across different governments is insufficient action to tackle poor diet across the nation, particularly in the poorest parts of the country. And that is driven by the relative affordability of foods and drinks that are high in salt, sugar, fat, compared to healthy foods. We also see it with smoking cessation services. We would really like to see the full restoration of the public health grant, which funds things like smoking cessation services, weight loss services. The government has committed to this current financial year's funding for smoking cessation services, but the cuts to the public health grant really did hit the most deprived parts of the country, and it's a real barrier to kind of bringing about more equal cardiovascular health. We could also look at things like more kind of place-based and community-driven healthcare, which has been in the news a lot recently, because as I said, there are real geographic inequalities in cardiovascular health, and we do need to meet people where they are in their given life circumstance, in their communities, and ensure that when we really push things like community pharmacy blood pressure checks, that they're actually funded properly and they have enough workforce to deliver what's actually proven to be on the ground, really successful initiatives. And I can tell I'm just about running over time, so just to briefly say how charities can help, and I won't just speak for BHF here, but we speak to patients every day. That's a big part of what we do, and we also have big kind of like analytics networks and subject matter experts who can help government and opposition parties formulate better policy. And because generally we are trusted as an independent body, the press come and they talk to us and they ask us for our opinions and things, and we always want to be a critical friend. We exist to fight for the benefit of cardiovascular patients across the nation, and we're not afraid to say something tough if tough advice needs to be heard, but also to generally congratulate where good policy initiatives have been announced and deployed to help people. I'll stop there.
Great, thank you very much. That's a really helpful deep dive into how these inequalities play out in one specific area of disease. Luke, if we come to you next, so what, in your view, should policymakers be doing to address the issues that we've heard about so far?
Sure. Now, I'm going to step it back a little bit because I'm a GP by trade. So, straw poll, I'd like to prefer an interactive audience. How many people in the last week can, hands up, say they ate 5 a day? Okay, what about how many of you managed to do 150 minutes of moderate exercise or 75 minutes of intense exercise? Okay, less hands. What about, do we have any smokers in the room? You may not want to put your hand up, but one or two, we should proportionally have some. I'm not going to get you to weigh your BMI and put that out here, but and we're at conference as well, so alcohol drinking. We're on the first night or second night, so maybe you've had your 14 units. But my point is, you guys are interested in health. You're sat in here in a room here today, and yet we're not even following the basic guidance for people who are educated, articulate, interested in this topic. That's the scale of the problem we've got. Add into that, when you look at the inequalities, you've got the ability of agency and priorities. If you are a single mum with 3 kids, where are you going to find your time to be able to go out and exercise? How are you thinking about what food we're going to get? You're going to go for the cheapest one that you can get to feed your family. So these are the problems that we face as a nation, and that's why I sort of started that. So how do we try and chip away and build the answer around it? And it's always reassuring as a politician when you're sat on a panel and you have an expert next to you that says they don't know either, because that's always helpful from my side. But it's our job as politicians to try and solve this. So the last government set about looking at the structures involved in this, and it's really important when we're talking about the regional side of things. This was the whole idea behind the ICBs, the Integrated Care Boards. We saw the Lansley reforms make changes, but the problem was it became a little bit more fragmented. The idea behind the ICBs was to pull it all together, to have all the people from social care to secondary care to mental health to charities to social services and councils all in one place, deciding what's best for their area. And the principle was really good, and I was on the Health Select Committee for 3 years, seeing how that panned out. And while everyone worked collaboratively, what became apparent was there wasn't the teeth. When it comes tight and budgets are difficult, how do you enforce shared working? No one had the final say, the crack of the whip. Fast forward where we are now, and the government's come out with a completely different direction. Happy to take questions on where we go there, but my observation here is, in my area in Leicestershire, we're now having our ICBs having to look for a 50% reduction. I'm also a 2-tier council going to a 1-tier unitary council at some point. That covers about 70% of social care costs, add in child services costs. We don't know who's leading on that. Is health leading? What about the devolution side? Is the council leading? Who's got priority on these bases? Add in the planning changes. Who's got priorities there? Suddenly, we're in a very difficult situation where we're not sure who is making the decisions and driving them. With the abolition of NHS England on top of that, it's going to be an interesting place for policy. There's real opportunity, and that's where the 10-year plan comes in. And from my point of view, I think whether you're a Green Party activist or a reform activist all across the board, I think most people would support the principles that are in there, the leftward shift, the digitalisation, these kind of things. What's missing is the delivery chapter. And how do we actually achieve that? That's what we're going to be spending a lot of time from our side looking at in the short term, because let's face it, the Conservatives are out of power for the next 3 or 4 years. Could be longer if you listen to some of the polls. But the flip side is that means we have the time to think about how we get our policy right. And within that policy circle, it's often the ownership of the left to be talking about inequalities. Whereas actually I see it very much something that's very powerful, and you're seeing more and more of, is how do we give people personal responsibility back? Everyone knows their rights, they're not so sure of their responsibility. And if I circle full round to when I was a GP, many patients would come into me and say, right, I've got diabetes, doctor, what are you going to do about it? I can't solve their diabetes for them, but I can give them the ability, the opportunity, the knowledge and the services to be able to them to manage it. And we need to get to a society where we can do that both at the individual level, at the regional levels of the councils providing the services, and then at government's level, because as you've seen, we can't keep spending in the health service without improved outcomes. So that is the debate that I'm looking to start as we build our policy base, saying how do we move things down towards people to take more agency of their control, so that at the end of the day we have more hands when I next come to conference going up to say actually 100% of the room understand what the mission is and how to make their lives better.
Great, thank you very much. So I'm just going to give a couple of questions to the panel and then we'll open up to the audience. So please start thinking about your questions now. Luke, the first thing I wanted to come to is the questions specifically that Tom put around issues like tackling diet and relative affordability of healthy food options, things like full restoration of the public health grant. What are your views on those topics, those things you want to see more action on? Do you think there should be additional action to make sure that the healthy foods that people should be eating are affordable to them?
Well, it's certainly, and this is where we start back to Arpana's point, you need the evidence base to back anything that you should be doing when it comes to policy. There is the wider side. So I come from a rural constituency. Actually, we've seen a swathe of people wanting to make choice to buy local. They want to support their farmers. They aren't to be able to track where their food comes from. But at the end of the day, cost is a big part of that. So I see it as a wider joined-up strategy of how do we actually make food production cheaper and more food secure to be able to get better quality food, which we know we have some of the highest food standards in the world. It's bizarre that we export those standards for cheaper stuff to import to feed our nation rather than actually encouraging people to make those better choices. So yes, there's definitely got to be some policy work of what that looks like. The danger is curtailing people at a time when money is tight, and we're seeing that. If you're losing your job, are we really going to then say, well, now you need to pay double for whatever it's going to be? And that's always the rub, the affordability versus the immediate impact versus the long-term sort of protective side we're trying to achieve.
Arpana, do you have any reflections on those comments or thoughts so far?
Thank you. And really important for us to invest in prevention via our public health, but also our primary care colleagues. And I think that's one of the key things for the operationalisation delivery of the 10-year plan that's in there. And how do we make sure that that's there? And the concept that we're trying to get across is that we can, through making every contact count, which is getting to the bottom of why that person's in hospital or sat in a GP surgery in front of you across the health and care sector. What are the drivers leading them to come to you? And food is a perfect example, due to the ability for us to think about evidence-based interventions that can help our communities, from growing all the way through to preparing food that's affordable. And I think one of the key things, especially with climate change, is that discussion that we need to be thinking about, whereas we used to be talking about heat or eat, but now it could be cool, heat or eat, as we experience different pressures on how we keep our populations healthy. And I think the last thing is that vulnerable ability for us to think across all of the sectors that we know influence health, and working with our policymakers so that we get the right thing at the right time.
Thank you. And Tom, what are your thoughts on the reflections from the Shadow Minister? Do you feel like that's going far enough? Would you want to see more? What are your reflections?
I mean, I think we'd probably want to see more, but obviously it's early days. And I think it's just important that when we think about how we make it easier for people to live a healthier life, because I think most people would want to live a healthier life. If you survey smokers, for instance, more than half of them say they wish they'd never started. Like, we have to accept that, as somebody else mentioned earlier, that, you know, if you're a single mom potentially working, you know, 2 insecure jobs with kind of, you know, irregular hours, where are you going to find the time to kind of get physical activity into your day? But I don't think we should look away from those evidence, the good evidence we have of public policy interventions that work in the public health space. So if we look back to some of the previous Conservative administrations, the soft drinks industry levy. Most drinks after the soft drinks industry levy stayed the same price, so for you control for inflation. So for consumers, it made very little difference, but what it did do was take hundreds of thousands of tons of sugar out of the nation's shopping carts. It made it easier for people to actually have to go to Tesco or Morrison's, whatever your local supermarket is, make essentially the same choices, but to have those choices be healthier. So I think there's lots of examples of many different administrations that we can look to where actually being ambitious, but also being kind of smart about public health policy and thinking about it in ways that, doesn't necessarily add cost to consumers, can still bring about like a real positive change and without actually making people's lives any harder. Because if you're living on the more deprived parts of the country, you'd have to spend a third of your take-home pay to meet the NHS's kind of dietary guidelines, and it's too hard. So any smart public health interventions that make it easier for people you're boon. But I wouldn't get too weighed down in kind of language around personal responsibility, because actually it's really hard, and we should look at what local, national government, the NHS, lives easier.
Great, thank you. So we'll come to the audience now.
Lives easier.
Great, thank you. So we'll come to the audience now. Please keep to below 30 seconds. I will have to cut you off. Very sorry about that. And please do try to go straight to a question rather than a general statement. And be nice to everybody. Great. We also have a member of the events team who has a raving mic, so please wait for her to come over to you before you ask your question. I will take this person at the back.
Hi, Robert Hansler from Cancer Research UK. We know that there is a big difference between symptom awareness as well as general willingness to do help seeking, to help those conversations. We also know that late diagnosis or later diagnosis is a big driver in cost. So to do these prevention actions, how can we save the the NHS money by getting earlier diagnosis through helping with help seeking from both sides and symptom conversations?
Okay, Luke, we'll start with you for that one.
Well, thank you. I think number one is the awareness side of things, people talking about it in the first place. And you've seen that much more with prostate in the last few years, that actually it's becoming much more acceptable to talk about it, number one, especially as we know how much of a killer it is for men as the leading cause there. Within that, though, you have to then say, okay, great, I'm aware of it, now what the hell do I do about it? And so if I look to my area, for example, we have a couple of charities that do PSA testing. Now there's issues about the PSA screening, we can discuss that if you'd like, but broadly speaking, they've got an awareness of what there's an issue there, and their wife may have nudged them, say, go and do something about it. They've got an ability to go and get something done in a local place, and then they've got the follow-up into the system. There you're starting to see a pathway that people can join. It's an acceptable pathway. It's built in a way that people can easily understand and track through it, and it's done locally without needing government to jump in and set a diktat. That's a really small example, but a really good example of how, if you can actually build a process around that, that's going to be very powerful. I often use my team will be bored sick of me saying this, but the sky cycling analogy, which was when sky cycling, for those of you who don't know, became so powerful, they looked at every percentage part of the bike, the rider, everything, the nutrition, on the basis that if you got a 1% gain on each part, on the cog, on the handlebars, etc., actually cumulatively, it makes a huge difference, and that's what they proved. And I think healthcare is a prime example of where you can do that from the ground up, because government can't keep telling you what to do in the diktats, because it doesn't work in the regional basis that we see. So it's enforcing and allowing people to do that.
Arpana, when it comes to low symptom awareness and late diagnosis, have you come across any of those issues in your work or potential ways to tackle it?
Thank you, yeah. And one of the things, again, is that postcode lottery. So how do we understand what is driving these? So one of the indicators we looked at was diagnosis in A&E. And I think that's one of the key indicators, is we shouldn't be finding the first time that somebody has a potential life-threatening tumour is in an A&E department, and thinking about that whole process of how we look at the fears, because the way we think about cancer may be driving some of these behaviours, and having an asset-based approach by where we're saying what is it in terms of that primary and secondary prevention. So things like smoking cessation, which we know is going to have the biggest impact on a number of cancers and different diseases, all the way through to then giving people the agency to not fear the diagnosis and be able to think about how they can navigate sometimes the complexity of the health system that Luke talks about, and be able to then get their diagnosis, because the second indicator we looked at was spread at diagnosis, and that is core to what treatment modalities are then open to individuals. And we've been investigating through our inclusive research that this is very different. So people here that are able to get to advanced radiotherapeutics and also chemotherapy agents, where are they coming from? And are they representative of the people diagnosed with cancer? And again, that's where we're seeing those inequalities. So these structural barriers are existing for our populations that we can do something about. Thank you.
And Tom, there are places where charities will play a big role in kind of trying to drive that awareness of symptoms, get people towards diagnosis. In your view, should that be charities doing it? How far do you think it should be charities like the British Heart Foundation or government doing that role?
I think there'll always be a role for charities, like both large and small. And we've got cancer research in the room. They've run very many admirable kind of public health messaging campaigns recently. But there is also an undeniable role of government, because charities, you know, for instance, British Heart Foundation, we are primarily a research organisation. We do have services, for instance, a heart helpline that people can call if they want to talk about symptoms or their experience with, you know, a qualified nurse, cardiovascular nurse. But so there is always going to be a role of large and small charities in speaking to the audiences that we know. However, the resource of charities relative to the resource of central government is minuscule. And we probably haven't seen the levels over many years of like robust, large-scale and targeted public health messaging that are necessary, because I know we've just been talking about symptoms, but particularly in the cardiovascular space, there are many of our conditions or risk factors don't have any symptoms. So there's a couple of million people in the UK that have undiagnosed high blood pressure, and they probably don't know it. They probably don't feel any better or worse than somebody who doesn't have it. So that kind of like national public health messaging, or targeted, if we do know we have communities where smoking rates are higher, is important, and I think it probably should be led by national government.
Yeah, we'll take a couple of questions this time, just at the front here.
Brendan from the Chartered Society of Physiotherapy. We've talked about diagnosis, but we rarely talk about the other end of the sort of care pathway. So in terms of rehabilitation, and we know there's a postcode lottery in terms of access to rehab, physios, OTs, etc. What can we do to make sure that everybody has access, whether it's fracture liaison services or stroke rehab, to really tackle that gap in healthy life expectancy?
Okay, any other questions? Just back here.
Hi, I'm Gemma from Marie Curie. Thanks to the panel for a really interesting discussion. Obviously, we are a terminal illness charity, so we focus less on the prevention angle, but postcode lottery is absolutely crucial to palliative and end-of-life care. And I particularly wanted to touch on that even though the last government introduced a legal duty on ICBs to commission palliative and end-of-life care according to local population need in the Health and Care Act 2022, we know in practice this hasn't been taken up by ACBs, and we still see huge inequalities in access across the country. So I was wondering for the panel's reflections on who should be leading this, where should this come from? Is this a national government, local government, ICB-led challenge? Who should be taking accountability and responsibility for tackling this postcode lottery across various health and social care services, but including palliative and end-of-life care?
So 2 questions there, both on kind of how you end up with this postcode lottery, what the drivers are behind it, and how you might solve it. Tom, if we come to you first.
Gosh, I've got a policy colleague in the room, and I'm looking at it now thinking, do we have what is our firm position on end-of-life care? But I would just echo everything that has kind of been said about the fact that I know I've talked a lot about prevention here, but cardiovascular disease is not just debilitating, but it is something that 1/4 of the people in this room will one day die from. If we're lucky, we'll die at a ripe old age, having lived a healthy, happy life. But it isn't good enough that issues at the very kind of end of the clinical pathway in both health and social care are patchy when it comes to ensuring equitable access. It shouldn't matter whether you come from, say, Rusholme or kind of like Stockport or Altrincham, if you live in Greater Manchester, about the likelihood that you get the kind of palliative support that you need at end of life. And I think we would broadly support everything that Marie Curie would probably say in this space.
Arpana?
I think for the rehab, it's absolutely fundamental, whether we're talking about cardiac, pulmonary, and I'm going to answer both questions sort of in a similar way, because we're really good in medicine at our protocol-driven services, but people don't often have just one thing, and I think that holistic approach to how we look at health and care needs to be integrated. So this is back to looking at services that have the populations that they are serving. And one of the key things, again, from our research is that often there aren't the resources to do something that's part and parcel of public health practitioners' approaches, which is a needs assessment approach. Because we are so data-driven, we often rely on the data that are already collected to formulate where we put our services. And if you're interested, I could tell you on some of the stories, because I can definitely say, if you build it, they won't come. And I think it's one of the key things about how we collect, analyse, interpret, and then use those data. And I think from government to local is core, because we almost need to go hyper-local. And back to that asset-based approach, I think for too long it's been more of a paternalistic, maternalistic, we know what's best for you. But if we talk that asset-based, place-based approach that Tom talked about, we've evaluated it with both policymakers and our communities, and it's absolutely core to giving away our power, because I think for too long we've kept the power. We're going to talk on behalf of you, but we've got those communities that are talking through our faith and voluntary sector organisations, through those community anchors that are actually able to give us the answers that we need.
So, Arpana, just on that, so what you're saying at the moment is sometimes you'll have big data sets, someone will say people in this community are really likely to have X kind of problem, therefore we're going to put some services in that area, but then people don't necessarily interact with those services. And what approach would you like to see? Do you think it's maybe use that big data at the start to find where there might be issues, but then go in at that point to the local community, or something different?
So start with the community voice, because they know, and they have that ability to be talking to us through our local councillors and other people that are the community anchors. So start there. The data are useful, and it's really important that we start integrating those data sets. And so what we can then do is see how the information can help us deliver those evidence-based, place-based asset ways of looking at those intractable issues.
And Luke, this question on postcode lottery, access to physios, access to end-of-life care.
Arpana, I'm stealing that. I mean, unashamedly as a politician, build it and they won't come. It's going to be the next manifesto for the services, I think, at this rate. Try and do this quickly. Care pathways, I think there's a lot of crossover in DWP here, needs to be better joined up for the rehab side, because we know the good news is actually, despite what we heard from the British Heart Foundation, with the prevalence, actually people are surviving longer, but with more complex needs as well, and be able to work. So we're getting many more people back into the workforce, but the workforce needs to change. So I was always surprised that you didn't come and see me as a GP for a sick note and then go straight in to see someone about how we're going to manage you back into the workforce. That's an oddity to me, because actually you've set that mindset straight from the go that you will be back to work, but we're going to support you. That's a really productive way, and I think that's where the rehab side comes in. I'm turning to yourself. Actually, let's go with the good news first. I don't think ever in certainly the last 20 years, has palliative care ever been talked about so much on the agenda. So that is fantastic with the assisted dying bill being put through. It has brought into scope, though, the historic nature of the way in which hospices come forward. I'm responsible for hospices in the shadow brief. The difficulty is you speak to hospices and they want the flexibility of having the charity funding to decide what they should provide, but they also want the government funding. And if you listen to the debate in Parliament, some people argue it should all be government funded, other people should argue don't touch it at all. I think there's probably a halfway house. The question is, what does standard palliative care look like? Well, that's very different and user dependent. And so we're back into the paternalistic side, because if we say this is the standard that you need to get, what is any commissioning going to do? Say, well, we'll commission the bare basics around it without, does art therapy count? Does being able to go and see Chelsea Football Club or Manchester United, if that's your religion? That's hugely important to you. So it's how do we build that around it? There's a conversation to be had, though, I think, in creating a framework to work within that allows you guys to innovate ahead, while also giving government backing and funding and security, but that freedom for the individual. I don't see it as a sort of one or the other. There's a basis to build in the middle. The problem is we're not seeing that leadership of what that currently looks like. That is the chance that I'm working for, to have this debate, to hopefully in the next 2 years come up with something that, the government says it's looking at this, but there's a space to work on how does this work. What will help do that is, many of you may have watched the assisted dying debate. One of the amendments that was put in on the nod that you may not have seen was the government has to produce a fully costed report of palliative care provision in the UK. That's really significant, because that will allow us to see what is really going to be needed at the bare bones to be able to provide that. So I'm quite pleased that got cross-party support. All parties nodded it through as a backbench amendment on. So that's going to keep the debate going. So I'm actually quite excited, even though it's going to get much worse before it gets better because of all the tax changes in the NHS and things like that. But actually, there is an opportunity there, and I see that opportunity.
Thanks. More questions? Just here.
Hi, my name is I'm from the University of Manchester. My question is, we now have emerging evidence that shows that faith-based organizations and grassroots organizations are delivering and getting involved more in health and social care issues, which for the most part, this was not why those organizations were set up. So should federal government play a stronger role in creating a national framework for supporting and strengthening the effectiveness of these organizations? Thank you.
Great. And then just directly behind her. Yeah.
Thanks very much. Chris Butcher from adult education charity, the WEA. Whenever we survey our learners, they always tell us that their courses help them improve their health, especially their mental health. And yet funding is increasingly going towards work outcomes, which is good, but less towards health outcomes. So is there a way of rebalancing that? And is there a role for social prescribing?
Well, and we'll take one more. Yeah, just there. Sorry, I meant the person next to you.
Oh, sorry.
I have a quick question about rural health. It was really good to hear you talk about farmers, Luke. I'm Kate, I'm from RABI, we're a farmers charity. I'm really interested in the panel's insights on managing health inequalities in rural areas where people are geographically isolated, but we also see sort of a cultural or behavioural issues where farmers often don't seek help until it's too late. So farmers are still dying of things like hernias, completely preventable, depression and mental health issues. And it sort of goes to the question just before. As a charity, we want to help locally. We want to listen to what the communities need locally and deliver it. But actually joining that up with the local health structures is proving a challenge. So any advice from the panel would be helpful.
Start with Luke there.
Oh, perfect.
I can tell you're ready.
Oh, no, there's so much to say in this space. Let's try and pull it together. Is there, I think the first question was around, is there a framework? I think there is, but again, the danger is having central government is it becomes too too prescriptive, and actually a lot of these solutions are going to come from local councils because they know their population and how to deliver it, which leads us on to social prescribing. I'm a massive advocate of social prescribing. If you say it to people, they don't understand what it is. You know, it was one of these big inventions about 5-10 years ago. And social prescribing is actually something really simple. You have someone in your GP surgery that tells you about the services. So if you've moved to an area and you're lonely and you're struggling, actually I'd, as the GP, refer you to the social prescriber, says, well, what are you interested in? Have you thought about joining the Rotary or the Cadets or something like that? Or I'm a single mum, I've moved to the area, my partner's just left me, where do I go? Well, have you been to this support group? That's a fantastic opportunity. So I really think we should be supporting it. And that allows us to support the faith side as well. But also it goes back to your point about the rural communities, because my big worry about the shift we're going to see in both the funding arrangements for local councils and the supposed change in the GP funding, for example, is going to move funding across to cities. And the biggest problem you have in rural communities is the sparsity that you have. And so there is hidden rural deprivation that you just don't see, because they just get on with it. They're the classic, the farmer who does just get on with it. And I always remember as a GP, if a farmer came to me and they told me they've got a bit of pain, always times it by 10, and it's 10 times worse than it should be, because they won't come in on that basis. So that's when you get into the opportunistic side of how do we build services where people are in the place so that they're seeing it. So hopefully that when they do come into either the GP, or more likely they go to the pharmacy to pick something up, or into their local supermarket or shop, are there services on hand that could actually opportunistically say, by the way, have you thought about this? The blood pressure checks, these kind of bits and pieces. Go to where people are, especially there's a difference between men seeking health behaviour and women seeking health behaviour. And when we're talking about the rural farmers, it's trying to get out to them in a different way to where are they going to be that you can then add services in. The problem is there's cost implications on that. And actually, a government's always got this hard point of, in the centre of someone like Manchester, you've got huge amounts of deprivation, but money goes to follow it. You've got the rural side that seems more affluent, but has individuals. That balance is really tough. No one's quite cracked it. That's not Labour or Conservative, and we swing from side to side. Somehow I'm hopeful that we might be able to find a sort of path through the middle.
Arpana, any thoughts on those?
Yeah, thank you. And completely agree about the national support for our grassroots level organisations. I think that's fundamental for delivery, and social prescribing especially has got a lot of the evidence base. So evaluation of major social prescribing programmes have shown that benefit, and one of the core things then is that where are we offering it and who is taking it up? So how do we make that ability to end the postcode lottery by some of these interventions that work? And I started off doing urban health as my research priority, but more and more what we saw was these same issues are there in the rural across Europe and wider that we're seeing in our cities. The whole issue is that the invisible populations are different, and being able to uncover these unmet needs, I think, is part of that locality that we're wanting to really form that basis behind, whether it's the ICBs or care sector, or another big project that we've just finished is on travel and transport. And we know that our rural communities have probably the worst public transport opportunities than our urban communities. And so thinking about these wider determinants is fundamental for all these three different questions from today. So again, I'll go back to that. Let's go back to the communities and the assets, focusing on those so that we can deliver interventions that can help.
Can I just chip in on that? No, because I think it's fantastic, and I wanted to give a concrete example. I've got a CDC, a Community Diagnostics Centre, £34 million investment in Hinckley. Absolutely fantastic. Put up the social media about it. First 3 comments were, but we don't have a bus to get there. This is the real problem of joining up government to think about that. And I don't think central government can do it. We've got to release the shackles on local government to be able to take that control. This is where devolution does make sense, but the problem is all the competing priorities haven't been set over which one interlinks what to be able to deliver for those different communities that have similar problems, but you don't have the data set to prove it. So.
And Tom, any thoughts on those three issues when it comes from a cardiovascular health perspective?
I think to touch briefly on the rural health point, I almost wish it was 12 months in the future, because we do have a rural health report planned in the next year, but I've not even started looking at the data yet. But interesting to know about the kind of like pockets of kind of like highly localized deprivation. I will bear that in mind when we do it. But I would just go back to the kind of call for the full restoration of the public health grant, because that is money given from central government to local authority public health teams to deliver public health services that meet their local authority needs. So if you want to kind of like a geographic, more kind of equity or equality, whichever word you want to use in the delivery of, this is mainly preventative services or kind of infectious disease services, but that delivering, putting money in the hands of local authority public health teams is a good way of meeting the needs of the local population's health.
Can I actually Tom and ask you then, with the 10-year plan, is one of the big pushes is for preventative care. Do you think the government's got that right then in terms of following the funding, or is it just good words at the moment to see?
I think it's still very early days.
Yeah.
I think from our perspective, for instance, we've got in the 10-year health plan, there's been an announcement of a modern services framework for cardiovascular disease. They had the new Labour government in the first decade of the 2000s had one, and that was very effective for bringing about an improvement in cardiovascular care, and it did have a preventative element. I think we'd like to see if what substance kind of comes from the 10-year plan. We're very actively engaged with consultations around the cardiovascular elements, and we are broadly supportive of the desires to move more community into care, because that is, whether it's a rural farmer you have to basically drag and kick and screaming to go see the GP, or somebody living in a very deprived urban part of Manchester who just doesn't feel particularly connected to the local health services. You do need to meet people, whether they're experiencing symptoms from something like prostate cancer, as mentioned earlier, or like they might have undiagnosed hypertension. But ultimately, if you can't meet people where they are in life, you are going to miss those people that the system is currently and has historically missed, because there are lots of people who are very good at engaging with primary care. But that's all well and good, but they're not the government set, for instance, a very ambitious target around reducing the rate of premature death from cardiovascular disease by 25%. But the people who are already going to the GP, every other week to check in with a symptom, or, who are very carefully watching what they eat, they're trying to get the 150 minutes of exercise a week. They're all well and good, but the way we achieve these big kind of like ambitious outcomes, which we fully support, are finding the people left behind with the system wherever they are, whether it's in an urban part of Manchester or a rural part of Rutland. And so community healthcare with proper funding and workforce is a good solution for that.
Thanks. I'm going to take a final question from the gentleman at the back who didn't get to ask previously. If you could each answer this question, then also give any of your kind of final concluding thoughts as well.
Thank you. Lawrence from Asthma and Lung UK. Tom, you just mentioned the modern services framework, and Luke, you talked earlier about taking the 10-year plan into delivery. Obviously, cardiovascular disease has got a modern service framework, cancer has got a cancer plan, but we know that respiratory disease is most strongly associated with deprivation of any major condition. So do you support that approach to sort of targeting disease areas where inequality is particularly bad through these specific plans or modern service frameworks?
I think we'll start with Arpana there. So a combination of, first off, do you think that more disease areas should have that kind of planned overarching approach? And then any final thoughts or reflections from the whole panel?
Thank you. So I am a respiratory doctor by background, so yes. I think it's fundamental when we're talking about pollution, because we know that we can choose to move out of areas of high pollution levels, and it's, as you say, associated across the life course. And if we're talking about things like indoor mold and the other household-based pollutants that are affecting our kids through to our most vulnerable older populations, that whole ability to choose and then to mitigate against those risks diminishes with poverty. And I think one of the core goals of this wider determinants where we link up all these different components are absolutely vital. And the other big link up, I think, with the amount of misinformation and disinformation is the informational and the commercial determinants. And so just to conclude, I think we've got this opportunity now, and another piece of our research has linked up health literacy with digital and financial, especially with so much moving into the digital. So how do we not leave any of our communities behind for whichever disease group we're talking about? And then how do we then mitigate against climate change and the changes to our environment that we're seeing? And we've got lots of different evidence-based approaches by where we can mitigate against some of these things that are either no cost or low cost. And then having that whole systems asset-based approach where we give away the power that we have to our communities and truly listen would be my final thing. Thank you, Becky.
And Tom, so obviously respiratory diseases are not your kind of main area, but do you have any reflections on how having that plan for cardiovascular diseases could benefit other areas? And then also just any final reflections?
Yeah, sure thing. I mean, I think one thing I would say is that we are supportive in the kind of sector-wide calls for a health inequality strategy, because whilst we're really chuffed to have a cardiovascular modern services framework agreement kind of in principle, or the promise of one in principle, we share many of our risk factors with the cancer research in the room, we've got asthma and lung, and for instance, air pollution. Over 10,000 people every year die from cardiovascular disease associated with air pollution. I imagine it's even more for respiratory disease. I imagine there's some cancer deaths in there as well. We share many risk factors with cancer. And I guess what I'd like to kind of close with is just that we've talked a lot about kind of like how inequalities in kind of wealth or deprivation can influence health outcomes, but we've not really talked a lot about how health outcomes can actually entrench deprivation and socioeconomic inequalities. And what I would like to kind of close with is a kind of passionate case for why we should invest in preventative healthcare. If you have a stroke, research from the ONS found this year that over the next 5 years, if you have a stroke in working age, you're likely to earn £14,000 less over the next 14 years. After the next 4 years, you are about 12% less likely to be in full-time employment, and you're significantly more likely to be receiving some form of government benefits. When you have higher burdens of preventable disease in more deprived areas, you also prevent people living up to their economic potential. And you subsequently entrench the kind of vast inequalities in kind of wealth, as well as life expectancy that we see in particularly the poorest parts of the country like Blackpool. And it's very easy in an era when budgets are tight and when people want to use terms like, well, in an age of both kind of all this kind of terrifying conspiracy theories about health, but also about, the enduring arguments of the nanny state. And there is always a case for personal responsibility in health, but tackling public health problems requires investment in public health, and it's cost effective and it has real human benefits. So I would just, when you're going to the other fringe events you go to over the next couple of days, just kind of bear in mind that investing in public health has a real return both for people and society, and even, God forbid, the Treasury.
Great. And Luke, just a couple of minutes left. Any final reflections on what you've heard on the question about respiratory health as well?
So, Lawrence, obviously, the last government had the major condition strategy that was also about to go, and which had respiratory side in. New government's taken a different direction, so we'll see what that looks like. And I get pulled from pillar to post by different campaign groups saying, well, what about us? Classic one was mental health, that's my portfolio, not really mentioned in there. Not much is mentioned there. Every minister was saying, well, it'll be in the 10-year strategy, and then we don't know what that looks like. So I'm open to it. We had some way of dealing with it. Let's see what comes forward with it. Parting comment, I guess personal responsibility at the individual person is really important. And Tom, I see where you're coming from for that. I also think personal responsibility goes to the organisations themselves. And let me give you the example. In COVID, the health service was able to change its pathways, its working, almost immediately, within a week or so. Suddenly, everyone was saying, we need to do this, we need to make the changes, and got on and did it. They didn't ask for permission, they were asking for forgiveness. What changed? That mentality has seemed to have lost again. And so how, as a clinician, now as a politician, can we enable those people to take responsibility for changing the pathways? Because they've got the solutions to their hand. And from a government's point of view, therefore, if you can empower those people to do it, like have better tech, for example, if I asked you guys to book a holiday to go around the world, stop at 10 places, you could do that on your phone now, and then I say tomorrow, cancel it all, you'd be able to do it. Try and do that in the NHS, barely get an appointment. Now, these are the kind of problems that we can sort out as government. If you make the working conditions better for the people in the system, not only will they be more productive, but they're also happier. And what will the 1.2 million people working there? They'll tell their patients that they're working better, they're happier, and patients will be happier. So I think there's a real solution here of actually empowering people to make those decisions and take responsibility for the decision. If I give you one final example, when I got my CDC, the very first meeting I had, logged into it to say, this is great, we've got the funding secured, who's delivering? I had 6 people come up on the street. After about 10 minutes of chatting, I said, guys, if there's a problem or you've got a problem and someone's going to come to me, who's in charge? And the answer was, we are. No, but who's in charge? We are. There isn't a one person. No one has accountability in the NHS. So lots of people, no one's doing anything wrong. A lot of people are doing things right, but also no one's got that responsibility to make that change. And I think I'd like to see giving more responsibility back to the local services and the regional areas to make those decisions and trust them to make those decisions and hold them accountable to make those decisions, because God knows Westminster can't do it.
Thank
and the
you.
final thing I want to say is I want to build it and they won't come. So that's
a good one to take away. Thank you so much to all of our speakers. A final bit from the Social Market Foundation just before we go. We have a weekly newsletter called Wonk Week. Each week we read through all of the major policy reports in Westminster and do a summary of those reports and send them out into your mailbox. So please do sign up on our website. And just a huge, huge thank you both to our panel and to everyone who asked a question as well. Thank you.